Somewhere on this ladder, you will hold a stranger's life in your hands and lose it anyway, through absolutely no fault of your own. And you will be expected to walk into the next room and do the job again within the hour. 9 levels stand between a first-year medical student and the person a hospital calls when nobody else can save the patient. The cost here was never measured only in money, and by the top of the ladder, most of it isn't measured in money at all. Level 1, the medical student. You're 23, 6 figures into debt that will follow you for the next 2 decades, sitting through your first year of lectures wondering when any of this will feel like the thing you actually signed up for. It doesn't. Not for a long time. Then, in your 3rd year, you're finally allowed into an operating room to observe a trauma case, a car accident victim, torn open in ways you'd only seen in textbook diagrams, and you stand against the wall for 4 hours watching a team keep someone alive who, by every reasonable expectation, shouldn't have survived the drive to the hospital. A trauma nurse named Yvonne, sharp-eyed and unhurried even in the middle of chaos, who's been working this same emergency department longer than most of the attendings have been licensed, catches you afterward, pale and silent in the hallway, and hands you a bottle of water without asking if you're okay, because she already knows the answer. First one's the only one that feels like that, she tells you. After a while, it just feels like Tuesday. You don't believe her. You will, eventually, and you're not sure if that's supposed to be reassuring. You spend the rest of that year noticing trauma bays everywhere you go, the way you never had before, glancing at the entrance of every hospital you drive past, reading news stories about accidents with a different kind of attention than you used to, imagining, uninvited, the specific sequence of moves a team would have made. Your classmates studying other specialties don't do this. You mention it once to your roommate, also pre-med, and he looks at you like you've described a minor symptom of something. Maybe it is one. Your first 2 years are almost entirely lecture halls and textbooks, memorizing anatomy diagrams and drug interactions with a classmate who becomes your closest friend specifically because you're both too exhausted to maintain any other kind of friendship at the same time. She wants dermatology, a specialty with regular hours and a much shorter road to a normal life, and neither of you judges the other for the choice, though you notice more than once a flicker of something like relief on her face when she talks about her plans that you don't feel about your own. You graduate $280,000 in debt, having chosen a specialty that will take a decade longer to pay off than almost any other path a medical degree could have bought you. You choose it anyway, and you're not entirely able to explain why, even to yourself, beyond the 4 hours you spent against that operating room wall and the specific, uncomfortable certainty that settled into you somewhere during the second of them. Level 2, the intern. Your first year as a doctor pays roughly $60,000 for 80-hour weeks that sometimes stretch further, making you one of the lowest paid people in the hospital building, despite the years of training and debt it took to get here. You make your first real clinical decisions this year, under supervision that thins out faster than feels safe, on patients who are, for the first time, entirely real rather than theoretical. Yvonne is still there, still working the same trauma bay, and she becomes the person who actually teaches you the job in the gaps between what the attendings have time to explain. How to read a patient's vitals before the monitor confirms what you already suspect. How to move with urgency without moving in a way that spreads panic through a room that needs the opposite. She corrects you, bluntly, in front of patients sometimes, because there isn't time for a private conversation about it later. You take the correction and keep moving. Everyone does. Nobody has time on this floor to soften a lesson before delivering it, and you understand within your first month that the bluntness isn't cruelty. It's the only version of kindness this pace actually allows. A patient you treated during your second month recognizes you a year later, stops you in the hospital lobby to thank you for a night you barely remember out of hundreds of nights that have blurred together since. You pretend to remember more than you do. It's the first time you understand that a single, ordinary shift, forgettable to you by the following week, can be the most significant night of someone else's entire life, and that this asymmetry, is simply going to be permanent. You develop, without meaning to, a strange, split relationship with your own memory, unable to recall most individual patients within a month, and yet able to describe years later the exact lighting and sound of a handful of specific nights in more detail than you remember your own birthday. Yvonne tells you this is universal in the field, that every trauma clinician she's ever worked with carries the same lopsided archive, full of gaps where 1,000 ordinary shifts should be and perfectly preserved footage of the 8 or 9 nights that weren't. You go without real sleep so many nights that year that exhaustion stops registering as a feeling and starts registering as your baseline. You make a small error in a drug dosage calculation during your 4th month, caught by a pharmacist before it reaches the patient, and you don't sleep at all the following night, running the mistake over and over, understanding for the first time exactly how much margin for error this job doesn't actually have. Level 3. The junior resident. You're doing real procedures under supervision now, closing wounds, placing chest tubes, running codes with an attending a phone call away rather than standing beside you. Your salary inches up to the mid-60,000s, still absurd relative to the responsibility, and the hours barely change at all. You place your first chest tube alone this year, no attending standing directly over your shoulder for the final 90 seconds of it, and you feel something shift in how the rest of the team looks at you afterward. Small and specific, the first flicker of being treated as a colleague rather than a trainee. You lose a patient for the first time as someone who actually made treatment decisions, not just someone standing in the room while others made them. A gunshot wound, bleeding faster than the team can keep pace with, and despite every correct call made in the right order, the patient doesn't survive. You did nothing wrong. It doesn't help. Yvonne finds you afterward in the stairwell, where residents apparently always go, and tells you the same thing she probably tells every resident who ends up in that stairwell, that the version of this job where losses stop happening to good doctors doesn't exist, and the sooner you accept that, the sooner you get to keep being a good doctor instead of a broken one. She sits with you longer than her break technically allows, saying almost nothing else, and you understand later that the sitting was the actual lesson, not the sentence she said before it. You call your old dermatology track roommate that night, the first time you've spoken in months, and don't tell him what happened, just talk about nothing for 40 minutes because you need to hear a voice that isn't attached to a hospital. He doesn't ask why you called. You're grateful for that more than you can explain to him. You go back into the trauma bay 90 minutes later for the next case. The hospital doesn't stop because you're grieving someone you met 2 hours ago. Neither can you. Not during a shift. Not yet. You cry in your car in the parking garage after the shift finally ends, 12 hours later, and you're back on shift again the next morning at 7, and nobody treats either of those two facts as remarkable, which somehow makes it worse and easier at exactly the same time. Level 4, the senior resident. You're leading the trauma team on shift now, calling the decisions rather than executing someone else's, teaching interns the same corrections Yvonne once gave you, watching yourself repeat her exact phrasing sometimes without meaning to. Your salary crosses $70,000, which finally starts to feel survivable rather than punishing, though the hours still aren't. A mass casualty event during your 3rd year as a resident tests everything you've built up to this point at once. A multi-vehicle accident bringing 6 critical patients into the department within 20 minutes, more than the trauma bay is technically staffed to handle simultaneously. You make triage calls under pressure that would have paralyzed you 2 years earlier, deciding, essentially, who gets seen first based on who's most likely to be saved by seeing them first. Everyone survives that particular night, which feels like validation and luck in equal measure, and you understand clearly that it won't always go that way. The hospital runs a formal debrief the following week, the kind normally reserved for cases that go wrong, and you realize partway through it that the debrief isn't really about identifying mistakes this time. It's about making sure the team remembers, in writing, exactly what a night going right actually looks like, so there's something concrete to measure the bad nights against later. You also start teaching interns for the first time this year, and you catch yourself, mid-correction, using Yvonne's exact clipped tone from your own intern year, the one you swore at the time you'd never adopt because it had felt so unkind. It doesn't feel unkind from this side of it. It feels like the only honest way to teach someone fast enough that the lesson actually saves a patient someday. Level 5. The Trauma Fellow. You specialize now. One more year of training beyond residency, focused entirely on the highest acuity trauma cases, the ones that don't just need a good surgeon, but a surgeon who's seen this exact catastrophic injury pattern enough times to move without hesitating. Your pay reaches the high 80,000s, still modest for the expertise being built, still nothing compared to what's coming. Yvonne, training fewer fellows directly now, but still working the same trauma bay after all these years, tells you this is the year you stop being a good resident and start becoming an actual trauma surgeon. The difference being less about technical skill, which you mostly already have, and more about the specific, uncomfortable calm required to make a life-or-death call in 11 seconds instead of 11 minutes. You get faster. You have to. The patients arriving at this level don't have 11 minutes to give you. A case during your fellowship becomes the one you'll reference internally for the rest of your career. An injury pattern so specific that your attending recognizes it before the scans even confirm it, calls the exact sequence of moves before making a single one, and saves a patient the textbook would have told you, a year earlier, was already gone. You realize watching it that the 11-second calm isn't confidence, it's recognition, built entirely out of having seen enough versions of the worst day of someone's life that this particular one no longer surprises you. You start keeping your own mental catalog after that case, quietly cross-referencing every new patient against every injury pattern you've ever seen, building the same library your attending clearly carries without ever describing it that way out loud. It's slow, deliberate work at first, effortful in a way that exhausts you more than the physical hours do. By the end of your fellowship year, it started happening without your permission, a pattern match arriving in your head half a second before you've consciously decided to look for one. Level 6. The community hospital attending. You take your first attending position at a mid-sized hospital, finally independent. Finally, the one whose name goes on the chart is the surgeon of record instead of a supervisor's. Your salary jumps to roughly $400,000, the first number in your career that actually reflects the decade of training and debt it took to get here. The independence is also the first time a bad outcome is entirely, legally, unambiguously yours. You're named in a malpractice suit during your second year, the case you handled correctly by every standard the eventual review confirms. But the process of being formally investigated over a patient's death takes 11 months to resolve, and you carry the weight of it every single day of those 11 months, regardless of the eventual outcome. You keep operating the entire time. You don't tell most of your patients it's happening. There's a specific week, deposition scheduled for a Thursday, 3 trauma cases still on your calendar for the same week, where you operate on a Tuesday morning with the deposition prep materials still open on a laptop in your office, and you're not sure, afterward, how you kept the two entirely separate in your head long enough to do either one correctly. Yvonne, reached by a late-night phone call during the worst week of it, tells you this too is simply part of the job now, in a tone that makes it clear she's watched other surgeons go through exactly this and come out the other side. The case closes in your favor. Nobody throws you a party for it. You go back to work the next morning, the way you always do, and the only real evidence it happened at all is a folder of documents you keep and never open again, filed in a cabinet drawer you nonetheless know the exact location of, in every office you've had since. Level 7. The Level 1 Trauma Center. You move to the highest acuity hospital in your region, the place ambulances and helicopters divert to specifically because it can handle what other hospitals can't. Gunshot wounds, industrial accidents, disasters large enough to need every trauma surgeon in the building at once. Your salary crosses $500,000, and the acuity of what walks through the door on a given Friday night makes your community hospital years look, in retrospect, almost gentle. You lose a patient here that stays with you longer than any before, not because you made a mistake, the review confirms you didn't, but because of who the patient was, a detail you learn afterward and wish you hadn't. Yvonne, who followed you to this hospital 2 years earlier because she said the community hospital had gotten too quiet for her taste, sits with you in the same kind of stairwell you once sat in as a junior resident and doesn't say anything for a long time before she finally does. She tells you about a patient of her own, decades earlier, before you'd ever met her, that she's never once mentioned in all the years you've worked together. Proof, she says, that the list doesn't get shorter, just older, and that carrying it is simply the toll for staying in a job that occasionally lets you win. You keep a small private list after that night, cases that changed something in you permanently, that you never show anyone, not even her. The pace at this hospital is unlike anything before it. A Friday night can bring 11 trauma activations before midnight, gunshot wounds and industrial accidents and highway collisions arriving in a rhythm that leaves no real space between one patient and the next. You learn to eat standing up, sleep in unpredictable 20-minute windows, and hold an entire second conversation in your head about the next incoming patient while still closing the current one. It stops feeling impossible around your second year here. It never stops feeling like something a person probably shouldn't be able to sustain indefinitely. A colleague you trained alongside during fellowship burns out completely during your first year at this hospital, walks off a shift mid-case handoff, and never comes back to trauma surgery at all, retraining afterward in a specialty with an actual schedule. You don't judge him for it, not even privately. You understand exactly which specific shift broke something in him, because you were on the adjacent table that same night, and you've spent more than one quiet moment since wondering which of your own shifts is quietly doing the same thing to you, 1 degree at a time, in a way you won't recognize until it's already happened. Level 8, the department chief. You run the trauma program now. Half your time spent operating and half spent on budgets, staffing, politics, and the quiet, constant work of protecting your department from a hospital administration that measures success in numbers that don't always match the ones you care about. Your combined compensation crosses $700,000 between clinical and administrative pay, more money than you ever imagined as a medical student, $280,000 in debt. You fight every single budget cycle to keep the trauma base staffed the way Yvonne always insisted it needed to be, and you win some of those fights and lose others, and the ones you lose cost more than money the following year, in ways an administrator 2 floors up will never have to sit with the way you do. You fight one particular budget cycle for a full week over a single overnight nursing position, a fight you eventually win by threatening, quietly and specifically, to take the staffing numbers directly to the local news if the hospital board cuts it. It's not a threat you're sure you'd have actually carried out. It works anyway. You understand, winning that fight, that Yvonne's entire career happened inside battles exactly like this one, fought by administrators before you who cared enough to have them, and that the trauma base she trained you in only stayed fully staffed because someone was willing to make that same threat, year after year, long before you arrived. The administrative side of the job teaches you a different kind of exhaustion than the clinical side ever did. No adrenaline to carry you through a budget meeting the way it carries you through a code, just a slow accumulation of spreadsheets and politics that somehow still costs you sleep at night, in a completely different register than losing a patient does. You miss operating on the weeks the meetings pile up. You schedule yourself back into the trauma bay more often than your role technically requires, just to remember what the job felt like before you were also responsible for everyone else's version of it. Level 9. The legend. There are surgeons whose names become the reason younger doctors choose this specialty in the first place. The ones residents across the country ask to train under, whose techniques get taught in textbooks written about, not just by. You are, after 3 decades, one of them, a fact that still occasionally surprises you more than anyone who knows your career would expect it to. You've trained more residents than you can count, and more than a few of them, somewhere out there, are correcting their own interns bluntly in a hallway, in your exact phrasing, without knowing where they got it. One of them called you last year, well past midnight, just to talk through a loss the way you once talked through yours in a stairwell, and you recognized the entire shape of the conversation before she'd finished the first sentence, because you'd had the same conversation from the other side of it, 3 decades earlier. Yvonne retired 2 years ago after 4 decades in that trauma bay, and you were the one who organized the party because nobody else in the building had known her longer. She told you that night, the closest she's ever come to sentiment in 3 decades of knowing her, that watching you become who you are was the actual reward of the job, the part nobody puts in a nurse's job description. A resident stops you in the same hospital lobby months later and asks how you actually knew, all those years ago as a third-year medical student, that this was the specialty for you instead of something with reasonable hours and a life outside the building. You think about your old classmate, the one who chose dermatology, whose face you still picture clearly even though you haven't spoken in over a decade. You tell the resident the truth. You didn't know. You still don't, some weeks. You just never once, in 3 decades, found a version of yourself that wanted to leave badly enough to actually do it. You've thought, more than once over the years, about showing the list to someone. A therapist early on suggested it might help, and you tried for exactly 1 session before deciding it belonged to you alone, not to a file in someone else's office. You still keep the list. It's longer now than you'd like, and shorter than the number of shifts you've worked would suggest, which is the only version of comfort this job has ever actually offered you. The question this ladder never quite lets you answer is the one that matters most: whether it was worth the marriage it cost you, the years of your own life you missed while saving strangers. The list you still keep, for the specific, singular feeling of being the reason someone's still alive to go home tonight. You've never fully decided. You've also never once, in 3 decades, seriously considered doing anything else. Your old classmate, the one who chose dermatology all those years ago, still texts you every few months, and the two of you finally have dinner together during a rare stretch when both your schedules cooperate. She tells you, honestly and without any edge to it, that she's never once regretted the choice she made, and that she's watched your specific path from a comfortable distance for 30 years, with something between admiration and genuine confusion about how you've sustained it. You don't have a clean answer for her, either. You just know that somewhere back in that operating room, 23 years old and pale against the wall, watching a team keep a stranger alive against reasonable odds, something in you got permanently rearranged. And every level of the climb since then was less a series of choices than a single decision playing itself out, 1 shift at a time. She raises a glass at the end of dinner, half joking, to the version of you that stood against that operating room wall at 23 with no idea what it was actually agreeing to. You raise your own glass back, and mean it more than the joke technically calls for. 9 levels. From a lecture hall to a name residents travel across the country to train under. 1 truth the entire way up: you don't get to save everyone, and you're expected to walk into the next room anyway. If ladders like this pull you in, there's another one waiting next week. Subscribe, and I'll see you there.